So for our next panel, we have a variety of folks. I'm going to let Tamara Daly introduce them, but this panel will give us some other non-traditional or non-academic research. I don't know, Patti, your research is pretty academic, but anyway, from non-academic sources and some opinion about what we've heard today.
Okay, right now I'd like to introduce Patti Boucher, who is Vice President of Client and Consulting Services of the newly formed Health and Safety Association for Government Services. Patti has more than 29 years of nursing experience in the community and health sector, 20 of them in the field of occupational health and safety. Please join me in welcoming Patti.
Hello, everybody. I'm going to kind of take the workplace violence, bullying, and looking at the issues with our healthcare workforce. I authored my first document back in about 1999 on workplace violence and the impact on our healthcare workers. And I must admit, we have progressed somewhat in addressing the issue of workplace violence, although it is a very complex issue, and I think that we have had some movement in the Ontario prevention system to recognize its complexity. I chaired a provincial group in the review of Bill 168 and the creation of prevention system resources to address the new legislation on workplace violence, which will very explicitly have requirements around harassment and, of course, workplace bullying is a type of harassment, as well as domestic violence in the workplace. So as you know, that legislation comes into effect on June the 15th, and there are very, very important implications for all employers, but particularly in the healthcare. We occupy the largest proportion of lost time injuries due to workplace violence, and so we've got some key issues to address. So we've adopted the workplace violence definition, and the OSHCO group was the Occupational Health and Safety Council of Ontario, comprised of the Ministry of Labour, the Workplace Safety and Insurance Board, and the Health and Safety Associations. Now that is actually, as you know, we've restructured again, so we've now formed 4 health and safety associations. So OSACH, of which we were previously, or I was at previously, now has become the Health and Safety Association for Government Services, incorporating education and municipal. But also in OSHCO is the Infrastructure Health and Safety Association, and the services and IAPA have come together. So what we did was we had equal representation from the HSAs with the Ministry of Labour participation in the WSIB, and we have developed a number of products incorporating the definition of workplace violence that is used in the legislation. You can, and actually I'm just going to comment above that, we actually also endorse the ILO, International Labour Organization definition of workplace violence, because the Ministry of Labour's definition very clearly is around physical harm, or the intent to cause physical harm, or imminent risk as a result of physical. And the ILO definition of workplace violence has more of a general connotation to it, so that it would recognize psychological harm. So the lost time injuries due to workplace violence or client aggression. You can see there that when we look at the Ontario incidents of all of the health and safety associations, healthcare occupies 32% of the lost time injuries, compared to municipal, who is fire and police, and education at 9%. When we really start to narrow down where these injuries are happening in the 7 rate groups included in healthcare, you can see there that hospitals occupy the largest proportion at 28% of lost time injuries. And I'm going to talk a little bit about hospitals, because when we actually zip down into the classification units in the hospitals, psychiatric hospitals, mental health facilities, and addiction hospitals have the highest rate. And that is alluding then to what are we doing about caring for those individuals. And I've actually been doing a lot of work with Ontario Shores on the implementation of the collaborative recovery model, which is an evidence-based curricula coming out of Australia, in really developing a therapeutic alliance and a person-centered care strategy in order to avert client aggression and responsive behaviors. So, and I think we have to get better about the way that we care for our clients and patients, because the majority of those incidents that you're seeing are in lost time injuries as a result of patient or client action. And I have a different theory, or somewhat, I wouldn't call it a theory, but I really do think that if we really concentrated on how we care for individuals, making sure that we're respectful, making sure that we have person-centered care strategies that are geared towards the sequelae such as dementia and psychiatric illness, that will be much more effective at reducing lost time injuries. In the group homes and the homes for nursing care, 25 and 21%. So those are the top three, and it's certainly where Ministry of Labour concentrates on their enforcement strategies around workplace violence in these top three areas. As you know, in long-term care, probably over 85%, I think, is the rate of the long-term care residents have some form of dementia. So again, points or alludes to care strategies. Group homes, those with have cognitive impairment and or physical impairment, and again, a special kind of care that we have to provide, person-centered care. So that kind of gives you what's happening in Ontario in terms of the statistics. And then in the review of the literature, the health of our healthcare workforce, healthcare workers are at greatest risk for workplace injuries and mental health problems. It's well documented. We have the highest rates of absenteeism than any other Canadian workers, experiencing 13.1 sick days per year compared to 7.8 for all other Canadian workers. Burnout is a huge issue in our nursing profession, and it's defined as high levels of emotional exhaustion, high levels of depersonalization, or low levels of personal accomplishment. And burnout is significantly linked with mental and physical health problems, and associated with a low productivity, the high absenteeism rates, high staff turnover rates, retention rates, recruitment issues, and is the precursor to mental illness. So if we're not paying attention to our healthcare workforce and providing those types of support mechanisms, encouraging the teamwork, our nurses are going to continue to burn out. The other thing, and if you look across Canada at some of the other jurisdictions that have, and the US with the Crisis Prevention Institute, there is a lot more support mechanisms that goes into providing that support for healthcare workforce, especially post a violent incident or violent event where there is a formal debriefing. We recommend the Flannery and Mitchell 7-step crisis intervention program, evidence-based and actually designed for emergency room and persons caring for individuals in a very fast-paced traumatic unit. 46% physicians are in advanced stages of burnout. 66% of new nurses experiencing symptoms of burnout, including depression, has resulted in nurses leaving the profession within 2 years of graduation. And depression and alcohol and drug use and suicidal ideation are serious concerns among our health professionals. So when we think about the issue of workplace violence and the complexity of workplace violence, we need to break it down into these 4 categories. I'm going to talk about the employee-related, but I don't want to undermine that. Type 1, the external perpetrator, somebody comes into your organization, commits a violent act against a healthcare worker, patient, resident, is considered violence. Client or customer or patient, this is where the majority of incidents are happening, although I must admit the limitations of the WSIB data because they only classify lost time injuries, so we have no idea about the healthcare claims, which, people seeking medical attention, although I was actually at a meeting recently that they're looking at classifying those claims for us so we can get better at prevention strategies. Type 3 is the employee-related. This is anything involving worker-to-worker, doctor-to-worker, supervisor-to-worker, worker-to-supervisor, anybody that has an employment relationship in an organization. And type 4 is domestic violence or personal relationship violence. So let's define workplace bullying. And Salen has done a lot of work and research on workplace bullying. It's a repeated and persistent negative act towards one or more individuals, which involve, and this is really important, a perceived power imbalance, which creates then a hostile work environment. Bullying is a behavior and choice. We've, in the last year, our organization's actually rolled out a lot of education sessions funded by the Ministry of Health and Long-Term Care on the issue of workplace bullying and domestic violence. But very interesting in these workshops. You know, after spending a half a day working with organizations through this training program about what is workplace bullying, the feedback that we've got, and even just the personal dialogue about people saying, you know what, I never realized, but I'm a bully. I never realized that I was a bully. So I think that's an important message to us, that we really do have to get better about building this awareness, because the nurses, for example, are eating their young. You know, there's lots of evidence to support, you know, new nurses coming into the profession, student nurses, or nurses with high levels of seniority on nurses with lower levels of seniority are not supporting each other. So I really do think that we have a lot of work to do in creating this awareness and the impact of this on our workforce, creating, you know, poison environments, creating environments where people are not happy at work. Bullying is increasing in health and community care sector 4 times more frequent than sexual harassment. It's implicated as the most concerning form of violence experienced by nurses. And the current state of workplace cultures has provoked a resurgence of attention to this issue. There's lots of focus on the culture of an organization and building this culture of safety, health, and wellness in an organization. Unfortunately, workplace bullying is really interfering with that collaborative effort to promote the holistic culture of workplace safety, health, and wellness. There's also evidence to support links between bullying and the current recruitment and retention crisis in nursing. Just some of the prevalence rates here. According to RAL, 81% of bullies are managers, 14% are peers, and 5% are lower ranking staff. Certainly that perceived power imbalance you can see here. A survey conducted by the Institute for Safe Medication Practices of over 2,000 healthcare staff in the U.S. reported the following: nearly half of the respondents experienced intimidation that affected the way that they handled medication orders, and 69% of the harassers were medication prescribers such as physicians. Physicians were condescending and or impatient when questioned about orders, and 48% of the respondents were threatened within the last year. Another prevalent study by University of Auckland in 2003, you can see there that in a survey of 551 RNs in their first year of practice, which is critical, new worker, unsupported in the concept of the team in the workplace, 1/3 of them experienced statements that were rude, abusive, humiliating, or involved unjust criticism. Over 50% reported being undervalued by other nurses. And over 1/3 had learning opportunities blocked. They felt neglected, they'd been distressed by the conflict between others, or thought they were given too much responsibility without the appropriate support from their team. Over 50% of the events described were not reported. Only 12% of those who described a distressing incident received formal debriefing. Again, that lack of support. And 1/3 of those who reported a distressing incident considered leaving nursing as a result.